Welcome everybody to the e-NISCHIT clinic today. Today we are going to be talking about the AIC activities, that is Airborne Infection Control activities which are required for the various ART centers. For this particular thing, the medical specialist for the day would be Dr. Satish, who is the Associate Project Director, and Dr. Sampada, who is the Program Manager for Strengthening TB Action and Response Project from Maharashtra. I would be moderating the session. I am Dr. Vikram Vohra and I am joined with by Dr. Vanna from Share India. Along with us is Mr. Ajit from Share India and Mr. Gaurav for Eco India. Now today's session is basically for Andhra and Tamil Nadu. So the talking will be the lecture and the didactic, everything would be in the English language. Now, just let me share with you, because of the upcoming elections, there would be no e-NISCHIT clinics for the coming 2 consecutive Thursdays. That is, because of the election at various places, we will not be doing it. All right. Now, before we go on further, let us just do the poll for attendance for the day. Please put up the poll for attendance. I would request everybody to kindly do the poll within the next 2 minutes. I request you to kindly hurry up with the pre-test poll so that we can go to the main didactic. Okay, we are ending the polling, and I would now request Dr. Satish and Dr. Sampada to kindly start with the didactic. Dr. Satish, please.
From Share India. First of all, I would really like to thank for all the assistance in really getting this presentation on.
Yeah, I'm able to see now. Yeah. Let us go to the second slide. So we would be covering our presentation in 4 bullets. We will be talking about airborne infection control. We will talk about the fundamentals of AIC, and then we will get you some practical information from the ART centers. We have done certain assessments and modifications were suggested in those assessments. So we will get some good pictures from there to really elicit our examples through the pictures in the ART setting. Next slide, please. So how do we define airborne infection control? A combination of measures is of TB transmission within the population. So all our efforts which we are making to minimize the risk of transmission constitutes AIC. And AIC, as we see, this is a common set. Next slide, please. As we see, there is a common. Yeah, in the picture you can see this is a common setting where most of our healthcare centers are all overcrowded, where you can find a lot of TB transmission, possible TB transmission happening there. So imagine a patient coughing in this area, in a compact area where where the spaces are all compact. There is poor ventilation. There is recirculation of air within the spaces, and here there is a possible TB transmission. So how do we really prevent this? So all measures what we do to prevent all this constitutes airborne infection control. So next slide, please. Government of India has issued AIC guidelines in 2010, and there is a link below which you can really access, and you can access these guidelines later on. So basically it deals with 3 components. We call it measures: environmental, administrative and managerial measures, environmental measures, and personal protective equipment. So these are the 3 measures which we actually undertake to make any institution or any workplace or any populations airborne infection control compliant. Next slide, please. We would go one by one into different measures now. Administrative and managerial measures. Here we are aiming at reducing risk of exposing clients to infectious diseases. Like the picture which we have seen, we are trying to reduce the exposure of these clients to the infectious disease which is prevalent around. The infectious bacillus, the droplets which are prevalent around, we prevent them from getting infected. So we aim stopping release of, we also aim stop releasing of infectious droplets. So what happens here is the source of infection. We also try to really prevent that source of infection into coming into general environment. Yes. In the administrative and managerial, again, if you see, we also undertake 4S screening and fast tracking, because the people who are actually showing symptoms need to be fast tracked so that they spend minimum time within the health centers, and providing surgical masks to the coughing patients. This is what we mean, that we need to really curb at the source of infection. So the lungs, as you know, if the person is infected, the lungs, the exhalation would be really dangerous. So we cover them on nose and mouth with the surgical mask, which really prevents those droplet infections coming into the environment. Then we also consciously look at avoiding mixing of patients at the general waiting areas. Like when we see the institutions, there are a lot of patients coming in for accessing different services, and so there is a lot of crisscrossing which happens in the waiting area or the passages and all. So we need to really very consciously build accesses where this mixing doesn't happen. And then in the administrative, one of the major important thing is we'll have to set up an infection control committee, and within the infection control committee, we should see that the AIC is spoken as an agenda point in that, so that there is focus on AIC also. So all the hospitals have got infection control committee. It's a mandatory requirement. So AIC should be included in those hospital agendas. Next slide, please. 4S, I don't have to elaborate much on 4S symptoms, but when the patient visits, there's an entry made into the patient visit register. The care coordinator first tracks this for patients, and then for symptoms, and then it appropriately referred to the staff nurse for confirmation of those symptoms and appropriately referring them. So this is the point where our triaging, our fast tracking, our screening activity, which starts at the ART center. Next slide, please. This is a low volume center where we have seen there's a good waiting space which is there. There are benches available, and patients are actually covering their mouth and nose with a handkerchief, which is a good practice which we have found in some of the areas. Then posters need to be displayed at a place. Next slide, please. Posters need to be displayed at a site where actually people are able to see, and there should be someone who can really demonstrate them as to what this cough hygiene means, what is expected out of them when they sit in those control areas. Next slide, please. So it is all the more important to place the posters in a place where there is a lot of crowding, and someone explains them on the posters as to what really need is expected from them, and so that will actually prevent possible transmission within those areas. Next slide, please. So when we talk about access, if it is a central waiting area where all the patients mixing with the general patients happen there, so there is a lot of chances that the infection can really happen. So we promote access from outside so that the registration and the access happens through a window. So that would come under a shed where there is a lot of place for people to sit in, and so a good ventilation is provided there. So wherever we have done these assessments, we have promoted this concept there, and people have implemented this very happily. Next slide, please. So explanation about cough etiquettes, whatever is available, because cough, as you see, a cough would not. It can happen anytime. So we'll have to actually use all the measures available at our disposal to do this. So how do we do this? There are different ways of actually doing. You can cough it in your armpit. You can take your kerchief and just cover your nose and this. And formally, you can also have a mask where it can be done. But the idea of showing this poster is whatever is available, whatever can really prevent from you sneezing out in the open area, would really these activities would prevent. Next slide. So people have been very innovative in the IC on the IC. Like the ART centers we have seen, they are very so active that they do all this messaging in their local language, and they actively display these posters at the ART center OPDs. Next slide, please. So when we summarize the administrative and managerial, on the left hand side you will see action and what that action will result into on the right side. So Triaging. Now, coming to triaging constitutes three important activities. One, you'll have to really screen them. You have to segregate the coughing patients, and then fast tracking of the coughing patients so that they jump the queue and they go to the either the counselor or the medical officer or the staff nurse quickly, so that the time between the spent between the registration and the diagnosis, of the time spent between the diagnosis and the initiation of treatment is minimized during that time. So we are really minimizing that time so that transmission happens at a very minimal low level. Cough etiquette and IC material on TB, safe sputum sample collection procedures, or implementation of biomedical waste management practices, all this will reduce infection and healthcare settings. So all these actions at the administrative and managerial level are reducing exposure to infectious particles. They are minimizing the time there and also reduce infection and health facilities. Next slide, please. So now I come to the environmental controls. Environmental controls, basically we talk about this to reduce the infectious particles. Now the particles have really come and formed around us. How do we really dilute those particles? So any activity which we do in this context is called environmental controls. And so the moment we say environmental controls, the opening of windows, opening of doors, free flow of air within, there is a free flow of exit out. So all the air which is there diluted gets diluted, and the infection is prevented there. Next slide, please. So keeping all the doors and windows open, prevent obstruction to optimize airflow. Most of the time we see in the centers that there is some obstruction to the windows. Either a carton box is kept or there is a poster which is displayed there which will prevent the obstruction. So all these things have to be really removed to get adequate environmental ventilation. And promotion of open waiting areas is the best. You can see a beautiful shed there in front of one of the ART centers where they have constructed this. And so a lot of patients really wait there for and the access also which I have shown from outside. All this promote environmental. Next slide, please. And when we see within the centers also, there are a lot of ventilators which are available, but the ventilators usually are found closed. So we have to make a conscious attempt to really open those ventilators so that there is free flow of air. So the hot air which goes up needs to really go through the ventilators out so that the fresh in comes in. Unless the hot air goes out, the fresh in would not come in. So there has to be a constant circulation of air within the centers. Next slide, please. The same example here, the windows now, the ventilators are now open. So the moment the healthcare workers come to know that this is for our good, then they immediately try to implement this. So before our assessment is over, we have many times seen that the things get implemented fast. Next slide, please. Another issue we have found in some of the ART centers is like we have constructed these cabins all through from top to the bottom, and we wanted to provide that confidentiality with the patients. The counseling chambers were done, but that was really not so good for the AIC. So we recommended that at least these partitions need to be removed. So half-covered partitions, like you see in the picture, promotes a good air ventilation there. Next slide, please. So in the top also we have seen a lot of places there is a lot of the ceiling is covered. So the ceiling has been removed, and in alternate places we have removed that. There may be a little discomfort in the thermal discomfort, but if you consider the hot air to go out of the windows there, so even opening the ventilator which is placed above this, you can see there. That also would really help. In one of the centers, they have opened that also, so that there was a good free flow of air from the meeting place, from the waiting area to the top. Next slide, please. This is from one of the ART centers in South India, and it was completely open. The sky was open to sky, and there was a good ventilation which was happening in this center, and there is a good queuing system which they have applied here. So this was one of the good places which we have visited in South India. Next slide, please. Now coming to the concepts of air changes per hour, I would like to briefly explain what air changes per hour is. Now if you see this, if you see this room, the fresh air needs to come in and the stale air needs to go out. So when we call it one complete air exchange is all the air which is entering in the room needs to go out, and all the air needs to be replaced by a fresh air. So in an hour we need to have number of cycles like this, and so for that we call it air changes per hour. Next slide please. So one air change has occurred when the volume of air entering or exiting room is equal to the volume of the room. So the entire volume of the room has to be replaced with fresh air. So we need to have so many fresh airs, 6 to 12 fresh airs, and for ART centers we need to have 12 air changes per hour. So other concept, we can actually measure this. There are 2-3 different ways of measuring this. So we would safely say that it would be good if we have a floor surface area of 20% floor surface area, which constitutes the openings. Now, if I take the volume of all the openings there, and if I take the floor surface area, so the openings should be equivalent to or more than 20% area, then we can safely conclude that there is ACH happening, adequate ACH happening within that room, provided there is free flow of air coming from one window or door and going from the other window. So the opening should be there for both sides, so that there is free flow of air which comes in from one and then goes out from the other. And there is some calculations which we also base our readings on. So there are 2 parameters which we look into: airflow rate, that is average velocity, and the air of the area of the openings of the windows and doors all put together. And then we also call something like room volume, length, breadth, and height, which we have, which we know, which is again calculated for the room. So air changes per hour is calculated as airflow rate by volume of the room. So this is how we calculate for each room. Next slide, please. And we'll show you some of the requirements, like the registration and waiting area. The air changes should be 6 and more. Outpatient department 6 and more. Inpatient department 6 and more. And high risk settings, and ART centers is considered as a high risk settings. So there we need to have 12 air changes per hour. So we have to really concentrate on providing good adequate ventilation here at this center. Next slide. The next slide shows you some of the equipments we use for actually determining how do we really measure this air changes. This is called AIC kit, which the team takes this AIC kit to each center. The first equipment which we are seeing, vaniometer, it will actually measure the airflow. And the second one is a laser tape. So standing at a location, we can really point this laser tape to any dimension of the room, and then that will actually give us the measurement, the length, breadth, and height of the room. So it's very easily captured here. We need not really stand on the stools and on benches and really measure. So laser tape gives you that advantage. And there's another thing which is called a smoke tube. A smoke tube will actually tell you the direction of the airflow, whether it is coming through the window, how it is exiting out. So that gives us a rough idea about how the wind is flowing there. And if you don't have a smoke tube, we can even use a essence stick, that is agarbatti, which is commonly available with us. So the team uses this equipment to actually measure this AIC. Next slide, please. Now there are certain processes also which we actually take care within the rooms. So when we see the medical officer and healthcare worker, so you can see a blue and a green seating place where the patient and the healthcare worker. So we also have to regulate this wind which happens, the airflow which happens between the healthcare worker and the patient. So it should not really flow from the patient to the healthcare worker, which is incorrect. So we will either have to have a column of air between these two, or it should go from the healthcare worker to the patient, presuming that the healthcare worker is healthy. Next slide, please. So here again, we are showing the flow of air from the healthcare worker to the patient, which is again a correct procedure. Next. Next slide, please. Yeah. So here again, as I said, a column of air in between the healthcare worker and patient, even this also is good. So we will have to actually see what is possible within that room. So the assessment team which goes to the ART centers, they will either say that the column of air should come from the patient to from the healthcare worker to the patient, or that a column of air can remain in between. Depending upon the local situations, this has to be seen. Next slide, please. And very often we see there is the exhaust fan. We also see a directional flow, a pedestal fan, or a table fan, or a ceiling fan there. So that also needs to be appropriately used here. So if you see the directional airflow, the pedestal fans provide directional airflow. Now, if your room is tight, the wind is not blowing there, then there could be a directional airflow between the healthcare worker and the patient, or there could be a pedestal fan behind the doctor or the healthcare worker which flows towards the patient. So we can use these different simple equipments which are available at hand to actually use. And one word of caution about the exhaust fan. On the exhaust fan, you can see a window also above that. Never keep the window open on the exhaust fan, because what happens is exhaust fan will pull in the air and again it will recirculate through the window back. So you are not really doing any good if the exhaust fan is there. So always see that the exhaust fan, the windows or any openings above or below the exhaust fan are actually closed. Next slide, please. Now, what happens when we take this action and the results which we see? Maximize use of natural ventilation, unobstructed open windows and doors, seating arrangements of healthcare workers, direction of airflow, ACH above 12 in high-risk areas. These are the actions we should really aim at, and that will reduce infectious particles in air, helps in dilution and achieving optimum ventilation. So all these actions will actually dilute the infectious air around us. Next slide, please. So whatever infectious particles are there around, so those not really infect. Suppose protection from airborne infectious particulates that have been already released in the environment, we need to really protect the healthcare workers. The health workers or the service needs to be protected. How do we do? So for this, you are next slide, please. Yeah. So I would like to spend a little time here to talk about what is a respirator and what is a mask. So the one which you are seeing on the right side is a mask, and one which you are seeing on the left side is a respirator. So respirator inhaling. So all what infectious particles are there outside, whereas in the patients, if you see the mask, the patient is already infected. There is a lot of infection in his chest. So when he sneezes or coughs, that droplet nuclei should really not go out into the environment. So it protects it from coming out. So one is for inhalation, one is for exhaling. So patients, it is important that they wear the mask, and the healthcare workers, it is important that they have a safe inhalation through a respirator. So these are the two differences here. And so the mask plays an important role with an infectious patient when he visits within the healthcare settings, and when also he remains within the house, so that the concentration of the droplet nucleus gets minimized. And when my colleague talks about this in detail, you will appreciate with good pictures as to how this happens within the setting. Next slide, please. So some of the do's and don'ts for respirators, N95 respirators. They are usually the N95 respirators should be really worn only when the fit test is done, and so the fit test has to be properly done. It must be replaced if wet or damaged or contaminated. So we have to really be careful about these respirators, and we should not crease or fold the respirators after use. Do not write anything on the respirators, because that can puncture it. And do not hang the respirators on the wall, because the elastic bands and other things can really get off, and there are likelihood that there's going to be punctures, or they can get infected from inside. So store it in a manner that protects against damage and contamination. Best is to put in a paper bag and actually store it once it is dry. Store in a manner that it protects the face piece from the distortion. The face piece needs to be really protected. The moment you try to twist it or squeeze it, then there could be some cracks in that. So that would not be again safe for you. So I would stop here, and I would request my colleague Dr. Sampada to actually take you through the practical aspects of this when they have actually done those assessments in the ART. Next slide, please.
Thank you, Dr. Satish. So I'm going to take you through some examples which will actually make all the concepts clear, which we have heard right now. So certain challenges that we came across when we visited the ART centers in Maharashtra were that there was a lot of overcrowding in the waiting areas, and there was a lot of crisscrossing of patients, mixing of ART clients with the other OPD patients. Many environmental issues that we saw were like sliding windows and obstructions to these doors and windows, display of IC material. So there were various challenges which we saw when we did some assessments. So I would be taking you through some 7 examples to actually bring the concepts clear, which we have currently heard. Next slide, please. The first example is for overcrowding, concentration of droplets, and use of surgical mask by patients. Next slide, please. Here I'm showing you a picture of a man who is coughing. So with this one single cough, you can see that so many particles have actually come out in the air. This you can imagine that this is one single cough. So if we place this particular situation in the box which you are seeing, which is the overcrowded settings in ART centers, especially on Monday and Tuesdays, you can imagine the TB suspects who are coughing in your waiting areas. So one single cough is going to release these many particles. Now these particles can either be smaller particles or the bigger particles. The bigger particles, heavier particles will settle down onto the floor. But the lighter particles will stay in the air and will be evaporated. On evaporation, what remains inside is going to be called droplet nuclei. So these are the droplet nuclei which are actually carrying the TB bacilli. And these are the ones which are going to be inhaled and then causing a TB infection. So next slide, please. So if you can see this waiting area, and you can imagine the situation that I've told you with one single cough, what can really happen and how many amount of TB bacilli would be in this area. We have shown in this picture that cough etiquettes are being followed by the patients. And you will see that what this small intervention is actually result into. Next slide, please. So with just covering your cough or following cough etiquette hygiene, you can see that the number of infectious particles which are coming outside of the patient are highly reduced. So one small measure is actually going to result into reducing the TB transmission in your health center. Next slide, please. Another thing, this if you're coupling with queuing of patients and not allowing patients to obstruct the doors, standing just haphazardly in your waiting areas. If you're having proper seating arrangements and you're having proper queuing of patients, this along with the cough etiquette measures is greatly going to reduce the risk of TB transmission in the waiting area. Next slide, please. The second challenge that we see is crisscrossing and mixing of ART clients. I will explain you. Next slide, please. So this slide is actually showing the expected patient flow in the ART center. We know that the patient enters the ART center. The first point of contact is care coordinator. From there, he goes to the counselor. From there, he goes to the staff nurse. From there, he goes to the medical officer. And from there, he is referred to whatever for the blood investigations or any other reference. Then he goes to the pharmacy, takes his medicine, and he's moving out of the ART center. So this is a routine flow. But sometimes what happens, we see that the rooms are placed in such a way that results in a lot of crisscrossing and the patient spending a lot of time in the institute. So please go to the next slide. Yes, I want you all to actually carefully have a look at this floor plan. This is a generic example that I'm taking, one of the ART centers. You can see the various rooms that are placed here. There is a care coordinator who is sitting in the waiting area. There is a room for staff nurse. There are total 3 counselors who are placed in one room. We can see there is a sample collection room, and then there are 2 rooms for the medical officers. And at the exit, you are seeing that there is a data manager and a pharmacy who are sharing one room. Right? So this is the floor plan and the structure of a given ART center. The arrows in blue that you are seeing is the airflow. That is the inlet of air is through the windows. And if you can see the passage is showing that the air is exiting out. The passage. Yeah. Next slide, please. Yeah. So now here, this arrow, the red arrows are actually showing you the patient flow, how the patient is flowing in the facility. So just keep on pressing the, yeah. So here the patient moves to the counselor's room. From there, he's moving to the staff nurse. From there, if required, he goes to the medical officer's room. From there, again, he's moving out and he's reaching the pharmacy, right? So here you are seeing the problem areas. There is a lot of overcrowding which is happening at the care coordinator. At the care coordinator and the pharmacy area. A lot of patients standing there, waiting there, and a lot of crowding that is happening at the counselor area. And of course, there is a crisscrossing. So how can we actually solve this? Next slide, please. Yeah, so now what we have suggested in this particular place is that if the 3 counselors who are sitting in one room can be redistributed into 2 rooms, and the sample collection which was happening previously in the counselor 1 room is now shifted into that vacant room. We have also changed the position of the care coordinator. If you have observed in the previous slide, it was below, and now it has been shifted over here. So now if we see the patient flow, let us see what happens. Next, please press the cursor. Yeah, so patient enters, is going to the counselor, going to the staff nurse, okay, coming to the medical officer, going to the pharmacy. Just wait here, just wait. Here you can see that we have asked the pharmacy to dispense the drugs from the outside. So the patient is not entering the room, but taking it from the window. There is an access that is made outside, and then he will be exiting from this facility. Next slide, please. Yes. The third example is about sliding or the closed windows. You know, sometimes we have seen that the windows are just broken, blocked, they are not openable, you know, and then there are sometimes a lot of obstructions that we see placed on the doors and windows. Next slide, please. Yes, so this is an example at one of the places where we had gone. This closed window was actually replaced by an openable type of window. So an openable type of window allows 100% of air exchange. We have seen that sometimes sliding windows are replaced, but we insist that you should be having openable type of windows in ART centers because that gives you 100% of air exchanges in the room. Next slide, please. Yes, this picture has already been shown. This is a waiting area, and these are the ventilators which have to be kept open because that will really help airflow. Next. I told you about the obstructions. Now this room is looking relatively airy, but however, it's been blocked by the curtains and the drug boxes. Sometimes it is blocked by the cards, cupboards, you know, so that kind of scene happens, and that should be avoided because that is something which is easily doable. We should have unobstructed ventilators, doors and windows. Next slide. This is one of the examples to show that if you have the will to do it, you will be immediately able to do it. This is an example to show that you are seeing on the left side there is a window and the upper panel is closed. And this room was in such a location that nothing much could be done for that. But we insisted that the upper part of the panel to be removed so that we are having some air exchanges in that area where the staff is sitting. So this was easily doable where you just have to remove the glass panes and the air change is good. So this was done immediately as suggestions were given, it was done. The fourth example is about the IC material at ART centers. Next slide. So we see a lot of IC material being pasted in the ART centers in the waiting areas. The cough hygiene posters need to be posted where they're likely to be seen by the patients. So we identified a place here, you see they should be appropriately placed. Only then they would be making sense. Next slide, please. The fifth example is for access to ART centers. Next slide. This is again one generic plan which I have for one of the ART centers. In the green, you're seeing the arrows in green are actually showing general OPD patients, other OPD patients who are accessing the facilities in the hospital. And please go back. Yeah. Yeah, and the ones in red are the the ART clients who are walking through the facility. So here we are seeing that they are accessing the ART center with 2 entry points. One is along with the other patients where they are getting exposed to other OPDs and sharing their waiting areas, and one is a restricted entry only, separate access for ART centers. Next slide, please. So what we suggested here is that if we could restrict this main entrance and allow only single entry to the patients, then it is going to actually aid the patient flow also and avoid mixing of the patients with other OPDs because they are more susceptible to infection. Next slide, please. The next is about N95 respirators. Next slide. This is a slide which is showing a medical officer and a counselor who is wearing N95 respirator. But however, during our experience and assessments, we saw that the ART staff is wearing surgical masks and conducting your OPDs and dealing with the patients. So we suggest that the surgical masks have to be used by the patients, and the staff, the ART staff and the healthcare workers have to use N95 respirators. It has to be used correctly and consistently for actually having results. Next. Yes, last but not the least, biomedical waste management practices. Next slide. Here we are seeing that the infectious and non-infectious materials are actually wastes are not segregated. The policy is not followed. It is not even displayed. So next slide, please. Good practices should be encouraged, and written plan should be available. And all the not just availability of plan is not the only thing. They should be implemented. The practices should be implemented, and they should be in place. Next slide, please. So, yeah, so the most important thing here is that I would urge all the medical officers and all the in charges of ART centers to frequently sensitize your staff on airborne infection control and bring those practices in use. Because frequent sensitizations and motivation is what the staff would need to actually bring the implementation of these practices. Next slide, please. To summarize, I would request Dr. Satish to summarize.
So we have actually gone through the theory and also the practical aspects of it as to what happens in the in the assessment, what are the recommendations in the assessment, and how fast the people really respond to it. Some of the places we have said a good sensitization which we do to the healthcare workers. Once they understand that this is for our own good and this is implementable, these are very simple things which sit on our decisions also, like opening the windows and removing the cartoons or removing the posters. All these things are very simple things which are actually immediately implemented. So by the time we give our assessment findings, we already see that these things get implemented. So that was a really good thing. And all that happened because the sensitization has to be really powerful. For every action, why are you supposed to do that? What is the philosophy behind that? If you are able to convey that properly, then it is likely to be really getting implemented. And someone has to really be a champion within the institution to really drive the AIC activities. And usually we have found that the nurses who are working there are very passionate about the AIC activities because the implementation of AIC activity falls on them. So they really take a proactive role. So it is left to you as to who really is going to lead at the AIC activities in the ART centers. But a good sensitization, a good logic, a good reasoning, and a good scientific approach to this, and everyone we feel that should be going through the AIC guidelines which Government of India has really issued. So if we take up all these measures, then we can safely say that we can make our institutions airborne infection control. Next slide. So we really thank all the participants and the e-NISCHIT team and the ECO team for facilitating all this. We are very glad to share our experience.
Thank you, Dr. Satish, for this particular didactic. I hope it would be of a great help to all the ART centers who have been online today. Now, before we go ahead, I would like to ask if anybody has got any comment to offer on this. Yes, Dr. Kalpana. Dr. Kalpana Calcutta, please. Madam, please unmute yourself. Unmute. Muted.
अनम्यूट किया था.
Is it okay? I'm unmuted the system.
Yes, yes, ma'am. Please continue.
Okay. Good afternoon, all, and nice presentation, nice knowledge I gathered. But I want to ask the presenter that during coughing, what is the distance traveled by the droplets? What is the distance traveled by the droplets after coughing? How far it can spread?
Yeah, it depends upon the how powerful your cough response is, and if, whether there is a prevention through the mask. So it all depends. And mask is not completely covered, so from the sides also it can really transmit.
Yes,
but,
without mask.
Without mask, it can really travel some meters.
Achha.
It would travel and go and hit the other end of the room also. So that could be the powerful. So
Okay.
the droplets we actually feel on our hand and all, even if you feel at 3-4 meters, but the droplets can really travel a long distance.
Okay. So what should be the minimum distance between the patient and the healthcare providers? Even both are having a mask.
Yeah, maybe 2.5 to 3 meters an operable distance.
Okay. And third question, and the last question. Actually, the OPD is centrally AC, where my ERT center is going to be shifted. So how can you control the airborne infection in a centrally AC hall? It's a big outdoor hall, centrally AC. So the ventilation and it's the opening the windows are not possible. So how do you maintain that airborne in that situation?
So it again depends upon the size of your room. Again, it depends upon whether the filters are used in your AC, whether a fresh air is filtered, and
So
then
should I see our administrators to use something? Can you advise me that I can contact my administrators and use these things to maintain the airborne infection control in OPD?
Yeah, the person who actually made most of the centers, what we have seen is the central AC is also put up with the filters and other things where the fresh air is pumped in, where the other air is sucked out. So there is a maintenance engineer within your institutions who will be able to really help you in that. But in small settings, if there is a central AC, small settings without any such facility of HEPA filters and all, then at that locations you'll have to we would recommend to put your windows and doors open and see that the thermal comfort is at least made. You keep the AC on, but at the same time you keep the windows open so that there is at least some little comfort on you for the thermal comfort is there.
Okay, thank
So
you.
Nice.
Thank you.
Dr. Kalpana, I would like to give a few comments about your questions. First question which you said was regarding the distance of the travel of the droplets.
Yeah.
Now, the distance the droplet travels depends upon the size of the droplets also.
Yes, sir. Yes, sir.
The heavier particles, the bigger particles, they tend to settle down much earlier than the lighter ones.
Okay.
And it is the lighter ones which are more important because you have to have a droplet nuclei which contains maximum of 3 bacilli. If you have a droplet bacilli more than 3 nuclei, it will just go inside your lungs when you are breathing, but it will also be taken. It will also go out. It is something like what you use in nebulizers. Okay. So the distance of travel without a mask is approximately 1 to 3 meters. All right, with the heavier particles settling down in the first 1 meter.
Okay.
Now, second thing which you said was very important because you see, being in a TB hospital over here, we also see this thing. When our residents join over here, they tend to keep the patients about 2 to 3 meters away from them. Now, when you are going to keep a patient 2 to 3 meters away from you, I do not know how are we able to talk to the patient, how are we able to examine the patient. We cannot do function as doctors.
Yes, sir.
All right. So the best thing in that case is what was told. Tell the patient to use a mask. In our institute, every patient is given a mask at the time of registration. At the same time, use an N95 mask and you can keep the patient next to you just 2 feet away. If you go to a private doctor's clinic, you will find the patient is sitting almost on the lap of the doctors. All right. In the government setup, we tend to be overcautious. But be assured, if the patient is using a mask and you are using N95, the patient can sit next to you. Alright.
One hand distance, as we say.
Yeah. And third thing, what you were saying about the infection control in a AC environment.
Centrally AC. When we
Central
don't have
AC.
control over the AC
Fine.
regulator.
Fine. You see, the paramount need of an central AC or AC environment is a closed environment. Alright. For an air conditioner to be effective, the engineers, they are going to make the place a closed environment. ACs are always a closed environment.
Yeah, yes.
Alright, so in a closed environment, it is also always going to be a difficult proposition to handle, especially TB patients who are expelling the nuclei. Why?
Yes.
Because the temperature is not high for the droplets to evaporate.
Achha, okay.
Alright, the nuclei which are droplets which are formed, they do not evaporate so easily as they do in a dry environment.
Okay.
Number two, ventilation is not there because you are having a closed environment. There is not much movement of the air. So in these cases, I would suggest we are using UV lights in our institute.
UV lights.
UV lights are there. These UV lights are hung from the ceiling. So what happens is that UV lights, when we are using the UV lights, the lighter particles, the property of the droplet, heavier will fall down, lighter will go up. And it may take about 36 to 48 hours for the light droplets to come from the top to the bottom.
Okay.
Alright, but they tend to go up. So when they go up, the use of the UV lights kills the bacteria and it can be a non-infective area. But, I am again saying but, it is never suggested to use a air-conditioned or a closed environment when you are handling a TB patients. If you are expecting that your patients will be having tuberculosis, do not use it.
Sir, in the center, the TB patient will come. With HIV and AT combined, patient will come. We cannot have a TB patient for a separate OPD, separate examination area.
Agreed. So in that case, you should follow what Dr. Satish has said.
Yes.
We also do the same thing. We have got air conditioners all in our rooms. We never put them on. Even if we put them on, we keep our windows open. All right. It is the policy of the I would say administrators to provide maximum comfort to the patients. The comfort is not providing a cold environment. The comfort would be to diagnose and prevent disease. So that part can be taken care by only yourself. Keep the windows open, keep the ventilators open, and there would be hardly any infection.
Thank you.
All right.
For a nice guidance. Thank you.
Anybody else? Anybody having any comment? Okay, I would just ask one more question from other people who are over here. Have you been visited for AIC activities in the last 2-3 years?
No.
Anybody, any AIT center which is coming up online on e-NISCHIT today?
No.
Okay, ma'am, not yours, because I understand South was being covered. Tenali, has the AIC activity, some activity of AIC been done at your ART center? NRI is here today?
Yes.
ART center, Tenali.
Sir. Good afternoon, sir.
Good afternoon, sir. Has any AICAE inspection occurred at your place for the ART center in the past?
No, sir.
Sir,
Voice clear.
voice clarity.
Voice clarity is like this, sir.
Sir, has your center ever been visited before for airborne infection control activities?
Once visited, sir. So 4 years ago, once visited.
4 years back. So, would you follow the recommendations which were given by that team?
Yes, we are following, sir. Mass, we are observing the. Yes.
Sir, follow up now.
We are following, sir.
But it has been quite some time. If you say 4 years, then at least I think the PPE, personal protection things you must have provided. But could you do the administrative part? Could you do the triaging? Could you remove the obstruction of the airflow?
Yes, we are following, sir.
Okay, good. Any other where AIC activity has happened in the last 3 years? Can you please give your experience about it? What you have been able to do after that? Sir, I would request all of you to kindly volunteer. See, this e-NISCHIT would go a long way if it is interactive. I am asking you a simple question. AIC activities at the ART centers have been happening since approximately 3 to 4 years. I think AIC teams would have visited your ART centers and they would have given you some recommendations. What I am asking you is, have you been able to follow up with those recommendations or not? Anybody? A.H. Anakapalli, can you respond? Are you aware of AIC activities at your center in the past?
Sir, good afternoon.
Good afternoon, madam. Please give your comments about any AIC activities at your center.
I have joined 2 years back, sir. In these 2 years, nobody has come. But
Okay.
previously, 4 years back, it seems they have come and given some suggestions.
Are you aware of those suggestions?
Yeah, sir. I have worked here only at that time.
Okay. So could you implement those suggestions?
They said they should not have any curtains and all the doors should be open.
So you have no curtains now and the doors are open now? Or are you still following the curtains and keeping the doors closed?
Sometimes we are, sir. Sometimes we are having curtains. When somebody visits the hospital like that, we wear curtains.
You see,
glass doors were there which were not removed.
okay.
Actually, they have advised to remove the glass doors, but we haven't. Our hospital people.
Good. Thank you. You see, this is what we want. We want to know from you what is happening. You are at the ground level. Unless you speak out, we cannot do it. If Dr. Satish and Dr. Sampada comes and gives you, this should be done, and somebody else also comes and tells you this should be done, you should bring up your difficulties in what it is. See, a lot of ART centers which I had visited, like Dr. Sampada had shown cartons of various drugs and medicines kept on the top of the cupboard. These places did not have any storage area. So when they did not have any storage area, they were forced to keep these cartons in those places which were obstructing the airflow. Alright. At times we have suggested that you remove your windows and make them air free. Issue is, the administration or the medical officer, chief medical officer has just made the windows over there, putting up an expenditure of 50,000 rupees to put up a window which is of sliding nature. And now we are suggesting, okay, make a new window, which they find it difficult to comply with. So these difficulties are not only at your centers, it is almost everywhere. So, but unless you come out and speak about these things, it will be very difficult to improve upon them. Alright. So I would request you to be in future, kindly be more interactive. We are not asking you any question which is concerning the course or any case or anything. This is general discussion. Yes, Dr. Vanna.
Yes. I was saying, sir, I think we are AIT centers are still a little hesitant, and although it's been a year discussing all these things, so I mean, we request you all to please come up and share your experiences. I mean, it's an informal platform where we discuss such cases, such information. So I think, and as Dr. Kalpana has said, that air-conditioned ART center. So many of the ART centers are in air-conditioned, sir, because the ART center happened to be situated in the OPD block, in the OPD building. In many OPD building, entire OPD building is totally air-conditioned. So these conditions happen. And so one thing, as Dr. Satish was also mentioning, that we can, do some infrastructural changes. But I think everybody of us would agree, Dr. Satish should also agree, that on a large basis, on a large scale, it's a little difficult to do the entire infrastructure change. So I think small measures we can use. For example, opening up the windows and then using the mask, and then putting the chair and table, sliding it, as Dr. Sampada has suggested in the diagram. So I think those little changes we can do easily.
Yes, I would agree with you, Dr. Vanna, on that. Yes, anybody, any comment? Yes.
Yeah, I have a comment. Like as a beginning, what we can do is the assessments which have happened 4 years back as a 3I project from the NACO,
Yeah.
there was a very good elaborate report with good pictures which was provided to all ART centers. I would request and urge all the ART centers to really pull out that report, pull out actually the recommendations which were given. And right now you have heard about AIC, so this is a good beginning we all can make. At least those centers where the visits have been made, please pull out those reports, go through the report, see how many recommendations have been done. And they were very simple recommendations which we have given, which are implementable there. We did not suggest that you break this room and do another room. We did not do that. So they were all implementable, very meager, small investment friendly recommendations which we have given. So I'm sure you will find this recommendations very useful. I myself have done almost in 18 out of the 30 centers which we have visited. I have done. So there are likely chances that you will find at least one of my reports within this center. So please go through that. NACO has really made a good effort. Dr. Rajesh Deshmukh was there at that time for you to recall his mail ID. Through his mail ID, this has come. So please see your mails and those pictures, presentations, those reports. Everything is available. Please take out that.
Thank you, Dr. Satish, for this. Okay, last thing of the day is the post poll. Just spent. Yes, Madam Dr. Kalpana, please. Unmute, Madam. Please unmute first. Dr. Kalpana, you need to unmute your mic.
Unmute. Already.
Yes, ma'am.
Okay, I want to please share the recommendation of AIC as he has said already sent to some centers, but I don't have. Please share with the mail the AIC recommendation guidelines and all.
Okay, Dr. Kalpana, I'll send you the publication which was done for this particular activity.
Okay.
As such, the guidelines which I have been told, the guidelines have been told in a bit broader manner by Dr. Satish, like it was administrative control, environmental, and the personal protection activities. Everything is basically has been discussed over there, but there is a publication also this, which was after the 4 years back when we had visited all the ART centers, mainly in Tamil Nadu and Maharashtra. I saw this publication. It was done, I think, the last year under the name of the. I will share it with you. I will give it to Dr. Vanna. She will give it to you. Fine.
Okay. Thank you, sir.
Thank you. Okay. Just the last activity of the day is the post poll. Kindly do it. Please remain with me for another 60 seconds. Fill it up. And for that time, let me thank you all for being with us today. And I would also like to thank Dr. Satish and Dr. Sampada for their presence and the Didactic today. Please put up the poll.
Does not play role in the transmission.
Another 10 seconds for the feedback. Then we'll be closing the clinic for the day. Thank you for your presence today. See you after 2 weeks once the elections are over. Please end the polling. Thank you.